Stand in one spot, right? Yeah. Oh. You get it to share?
We should be good.
We're good?
It's
Okay,
recording.
it's recording. Everything's working. Not quite working yet, but we get it there. Uh-oh. Did it change?
There you go.
Okay, there we go. It's not, oh, it's not syncing up. That's it. Now it's syncing. Okay, I think we got everything there. Good afternoon, everyone. I think it's afternoon now, right? All right, and also too, to thank those that sent me a very nice fruit basket that came in. I really enjoyed that. That was a real surprise. Real surprise. Okay, that means I gotta work harder now, doesn't it? We're trying. Okay, anyway, we're gonna talk about the local anesthetics today in the space that we have. And with those quick introduction is they're widely used to control pain. I'm still talking about pain control and everything. This is a painless, hopefully a painless treatment. It should be a painless treatment and should be comfort to the patient. So as a definition, what is a local anesthetic? And these basically are agents that interrupt pain, such that the impulses within a specific region of the body could, without the loss of unconsciousness, as opposed to the non-elective general anesthetics. This one, there's no loss of consciousness. This is normally completely reversible, and we hope that it is until I talk about some of the adverse events of it, and some of those are and some of those aren't. So in terms of quick history, cocaine was really the first of the local anesthetic that came about, and it was used at some time. I'm not going to spend much time on that. Chemistry now, very interesting in that it has really three major regions: the aromatic ring, the intermediate linkage, and a tertiary amide linkage that goes with it. Most important part of this in terms of the chemistry are the intermediate linkages that are there. Is either the amide linkage, and the amide linkage, it is metabolized by the amidases in the liver, whereas the ester linkages are metabolized within the blood by the pseudocholinesterase enzyme that is not acetylcholinesterase, but by the pseudocholinesterases that are in the blood and is destroyed by that. So don't make that mistake there. This is just another picture of how they look there. Now, in terms of their classification, we classify them according to several different classification techniques. One is by their linkage type, whether it be an amide linkage or whether it be an ester linkage. And under that, we have subclassifications of the long-acting drugs like ropivacaine, and these drugs are lasting sometimes up to about 4 or 5 hours. Whereas the intermediate acting drugs, lidocaine, ropivacaine, prilocaine, ester linkage type, again, the long-acting drugs, the tetracaine. Intermediate acting is cocaine. The intermediate acting, by the way, I mentioned earlier, they're lasting anywhere from 2 to 3 hours, somewhere in that neighborhood there. Then the short acting drugs, which primarily you're exposed to, is procaine, chlorprocaine, benzocaine. These are the ones that last, well, anywhere between a half an hour to an hour, maybe 90 minutes is long in terms of their lasting that is there. Also, when we talk about the ester type linkages, like I mentioned, these are hydrolyzed in the plasma by the pseudocholinesterase. And the most interesting thing about the ester type linkage of drugs is that they produce, in terms of metabolism, para-aminobenzoic acid. And this is the common event that's seen in allergic cases. So if you're allergic to one of the ester type linkage drug, you're allergic to all of the ester type linkage. Look like I may have to hold this. It's not gonna work. All of these would have to be eliminated because you'd be allergic to all of them in terms of the ester type linkage of drugs. This is not even on. So I have to pick it up. I thought this was on. Let me see here. Hold on a second. Doesn't really seem to be working at all. Is it plugged in? Fine, I don't need it.
You sure?
If you make it work, I'll keep going. If you can make it work, then I can just hold it. The light is on, nothing else is working. Oh, here. I'm sorry.
Oh, okay. Can you talk into it so I can make sure it's not too?
It's working. They always say check the switch, you know? When sometimes when we have instrumentation in the lab and we have a piece of equipment that's not working, and the technicians, the first question they always ask before they even come, did you turn it on? Okay. Did I turn it on? So anyway, I'm not starting over, but anyway, I think I've got the message across with the parabenzoic acid type of system that is there. Is that if you're allergic to one of those that has an ester linkage, you will be allergic to all of them, which means what? Convert over and start using one that has the mild linkage. Same difference that would go on there. Same thing with the mild linkage type drugs. Like I said, these are metabolized in the liver. In terms of inactive metabolites, and it's rare for a person to be allergic to the amide type linkage drugs that is there. Now, going back to the classifications, you can base it upon duration of action. Ultra short, short, medium, and long acting drugs, depending upon exactly where the drug is actually injected. The pupil has an onset about, and it will last about 10 minutes, so very short, ultra short. The short acting drugs, maybe up to, again, about 10 minutes, they're not gonna last very long. But in the soft tissue, they can last up to 2 hours. That will be there. Medium acting, about 90 minutes in the pulpal tissue, and soft tissue a couple hours or more. And then the long acting drugs, like I said, pivocaine or pivocaine. Some of those type of drugs can last up to sometimes 4 or 5 hours that a person would, once they're given those. So these are the very long acting drugs. You have to have a good judicious use to use a very long acting drug of that length. Because before a person, let's say, leaves your dental theater, then you want to make sure that the drug has about worn off. You don't want to have it worn off and 5 hours later, they're still numb. That's not something that you want to see. Also, it's based on potency. We have the low, intermediate, and high potent drugs that will be there. And so this is usually the ways a lot of these drugs are classified in terms of their set. Now, properties of a local anesthetic of an ideal must be reversible, which I've already mentioned, that they have to be reversible. You can't have it work and it doesn't stop. It has to be reversible at some time point, whether it be as short as 10 minutes or as long as 5 hours, but it should be reversible. Must be non-irritating to the tissue where the drug is actually injected. You don't want a drug that's going to cause irritation to that person for the most part. Low systemic toxicity. Most times you don't really think about that these drugs can be toxic, but they can be. And they can be toxic to the point that can be fatal. So you want to make sure that when you inject, you have to be careful where you inject these drugs, not into a vein or an artery, but to make sure that they're injected into the tissue. Because if they're injected, and I'll talk about it when we get into the toxicity, it could be a fatal event that can take place. This potency should provide complete anesthetic agent that's going to be there, and the duration should be enough time that you can do what you need to do for the time that is allowed. So if it's something that's going to take 2 hours, don't use a short acting drug that wears off in 60 minutes. And then you have to re-inject again. You don't want to have to do that. You want to inject one time only, and then move on, do what you need to do, let the drug then wear off for the most part. Relatively free of producing allergic reaction. You shouldn't have to worry about that if you use a live type linkage drug. And a lot of times, this actually now they just tend to use just a live type linkage type of drug. Why? I'm gonna ask the question, have you had this drug before, and did you have an allergic reaction? So it's just easy to start with a non-type linkage drug. Should be stable when it's within the body. It should be stable also, that it can be sterilized without breaking down as well. Now, obviously, no anesthetic agent fulfills all of these type of requirements, but they come very, very close out of there. So let's move on to the mechanism of action that's going to be there. the long and short of it is that the two things, local anesthetics bind directly, okay, bind directly to the intracellular voltage dependent sodium channels. Now that binding that they do bind is on the inner surface. I'll show a picture of that on the inner surface of the sodium channel. And they block primarily open and inactive, okay, open and inactive sodium channels when they're there. Now, to give you an idea of what is an open inactive channel, we have two doors here in this room. Right now, these doors are open, but they're inactive. No one's going in, no one's coming out. So that makes it an open inactive doorway or channel. And if we close the door, that is a closed inactive channel. And by 2 o'clock, when we're all done and we leave the room, that becomes an open active channel. Okay, so that's about the best analogy that I can give for that. So a little more of the details in terms of the mechanism of how they work. Primarily, these drugs will go through the sodium channel and they bind to the inner surface of the sodium channel, causing the bulk membrane to expand. And when it expands, sodium can no longer flow through that channel. Again, that's an open inactive channel. But if I go to the channel and I stand in the way, you can't get out of the door. Obviously, you're pushing out of the way. But the idea is if I'm there, you can't just walk through the channel. And the same thing with sodium, you can't get through the channel because it basically is closed off to some extent. And therefore, if the channel is closed off, there's no generation of an action potential. There's no generation of an action potential. There's no propagation of an action potential that will be there. And therefore, by giving a local, you don't feel the pain when you're doing whatever you need to do. The lipid soluble local anesthetics can easily penetrate the lipid portion of the cell membrane. They go right through the cell, but they also still bind to the inner surface of the sodium channel itself, and therefore there's a decreased diameter of the channel. So again, sodium cannot flow in, potassium cannot flow out. Okay. So what we look at it there again is that the action potential is not generated, and without an action potential, there's no depolarization that's going to take place at that event. So if we look at just a regular sodium channel, again, thinking about the doors that are in this room, this isn't a resting closed channel that's here, okay? And this is an open, which is brief. Sodium will flow through, potassium will flow back out. And if it's inactivated, then it is closed off because the local anesthetics have blocked the channel from the inside, not on the outside. There's no receptor on the outside of the channel, but on the inside. So the drug actually has to flow through the channel and block to the inner surface of the, there's a better picture here. It actually blocked to the inner surface of the sodium channel in and of itself to block it by causing a decrease in the diameter of the channel. And again, sodium cannot flow in, potassium can't flow out, no generation of an active potential that takes place. Now, where are these sodium channels actually located? Primarily, they're located at the nose ranvier, where we do find it. At the areas here, we find a fairly high amount of myelin sheath that are on the channels, and because the myelin is there, the drug doesn't flow through, and therefore we find the sodium channels primarily at the nose ranvier that would be there, and that's where the local anesthetics would block for the most part. Now, looking at a little more of the mechanism of action of these drugs, there's a slow rate of depolarization, and this also reduces the height of the action potential. So the drugs don't have 100% in terms of a blocking of the generation, but it blocks most of it, a good 90 to 95% of the generation of the drug that will be there. Reduces the rate rise of the action potential, slows the axonal conduction, ultimately prevents the propagation of the action potential from node to node as it's going through solitary conduction, and therefore does not alter resting. It also does not alter the resting potential that will be there or change the threshold. Now we know that for a cell membrane or a nerve, that it has a resting potential of what? -70 millivolts. Okay, we all know that. And then it gets to its gate threshold, which is about -50, -55 millivolts. And once it has reached its threshold, you have a depolarization. where sodium is going through the channel, potassium is coming out of the channel, and you have the overshoot that's going to be there. It's about plus 30 millivolts, and then it decreases back down again as potassium channel gates open. So you have a repolarization and then a hyperpolarization here, number 5. The hyperpolarization point is very important because it says no matter how strong the stimulus is at that point, the succeeding train of stimuluses, they cannot elicit another action potential until the nerve actually comes back to its resting potential again. So when we look at it in terms of the sodium channel block, that same thing. This is again at minus 70 millivolt. But if I give a local anesthetic, what it does, it decreases the rate of rise of the action potential. There's an increase in the threshold potential from a minus 55 up to maybe a minus 30 or minus 25 millivolts. The overshoot is much less than before. Very small overshoot that would be there. And the most important thing is the resting potential for the repolarization phase is anywhere to 10 to 100 times longer than normal, which means if there are other impulses that are coming down the line and hit that one point, they will stop at that one point because the resting potential is so much longer, and therefore, no matter how strong the stimulus is, it will not elicit another action potential. So a real quick summary of so far what I've talked about. Local anesthetics will block the action potential generation by blocking the sodium channels that we've already discussed and we know about. Okay, the local anesthetics are amphiphilic molecules, and that they have both a hydrophilic and a hydrophobic end. So the tertiary mean is hydrophilic, the aromatic end is hydrophobic. That is there, and they are linked together by either ester linkage or they're linked together by the mide linkage. That is when the intermediate linkage chain. And that intermediate chain also, I did mention earlier, the length of that intermediate chain also to some extent determines its onset of action time as well as the duration of action that will take place. So the longer the chain, the longer it's going to take for that onset. Shorter the chain, the short duration and a short onset that would be there. Also, this is one that's very important here. Local anesthetics show what is known as a use dependence. What does that mean? When a nerve fires, it fires at a certain hertz, hertz amount that's going to be there, anywhere from 100 to 1,000 hertz that the nerve fiber is firing at. The faster the nerve fiber is firing, okay, because it has been stimulated, the more time that nerve is actually going to have a propensity to be in a open, inactive state. Yeah, let's sink in a little bit. If we had this door opening and closing at 10 times a minute, as composed to 100 times a minute, how long will it be in the open, inactive state? It would be longer in an inactive state by opening and closing at a much faster rate, which means that the local anesthetics are going to work on those nerves that are firing at the fastest rate. Okay, we say that again. It's called use dependence, or another name known as frequency dependence. Those nerve fibers that are firing at the fastest rate are going to be affected first. Okay. So it really depends upon how fast that nerve fiber is firing. To let us know. The other part of his use dependence is mainly also reports in relationship to his antiarrhythmic as well as to its anticonvulsive effects. I'll come back and I'll talk about those two things in a moment because they become very important in terms of the sort of theoretical use of these drugs. Now, in terms of the blocking order that they have, the small myelinated axons are affected first, the non-myelinated axons, followed by the large myelinated axons that are going to be last. So your pain and sympathetic transmission is going to be blocked first. So let's look at any questions so far. Anybody have any questions? No? Okay. Factors affecting the affected one is pH. Okay. Charged cationic molecules bind to receptor site uncharged. So that it says what the local anesthetic for it to go through the channel has to be in its uncharged state. Okay, it can't be in a positive charged state. However, once it does flow through the channel, once it flows through the channel, there's a disassociation between local anesthetic or the drug and its salt that goes with it. You know, we talk about ion pairing. I think my very first lecture, I talked about ion pairing. This is an example of ion pairing. Once the local anesthetic has flowed through the channel, it disassociates and then it can bind in its cationic form in the sodium channel itself. Okay, so if there's alteration in the pH that'll take place, then it will change what's going on. Normally, there's about a pH range of 7.6 to 8.9 that will be there, and primarily closer to that, 7.35 to 7.45 in terms of the pH within the tissue that's going to be there. Therefore, that means that the drug is going to be in its unionized form, flows through the channel, disassociates, and now it has a faster onset of action. However, when there is an inflammation, there's an abscess that's in the mouth, and you inject in the area of the abscess, what goes on from that area? First problem is it creates a very acidic environment and a lower pH. The problem with that, you're going to have a disassociation of a local anesthetic on the outside of the tissue or the nerve fiber instead of on the inside of that nerve fiber, which normally would think, well, I gave you an injection, it didn't seem to work very well. You do what? You inject again. Still didn't work, you inject again. So now you've injected at least 3, sometimes even 4 times you inject it in the same place, and now you're scratching your head why the drug didn't work. The reason is because the drug disassociates to its cationic form on the outside of the nerve instead of on the inside of the nerve, and therefore very little of the drug is going to actually do anything at all because of the inflammation that is there due to the abscess, and therefore the drug just is not going to work. What do you need to do? You need to inject them higher in terms of the nerve trunk. So if you inject away from the inflammation spot, inject them higher in the nerve trunk itself, then you would have a decrease in the, you would have an effect of the drug, and therefore you have the anesthetic effect that would take place. This becomes very important because as you increase the concentration of the drug, you increase the chances of its toxicity that can take place in an individual. So don't just keep injecting in an abscess and wonder why it's not working. The reason is you're in an acidic environment, so it will never work in that area. Alternative is lipophobic. Those drugs that are highly lipid soluble, they are more potent as a local anesthetic, which means they will flow through. They will flow through the nerve fiber and get into the sodium channel at a much faster rate, and therefore they will work much better and sometimes even longer than some drugs that are not very lipid soluble. Now, remember I told you about the lipid solubility is due to sometimes the chain, intermediate chain that may be there. Okay. Other effects that may be there, effective protein binding, increased binding also increases the duration of action. So the longer that it binds to the inner surface of that nerve, then it's still going to work because the diameter, remember the diameter of the nerve fiber has been decreased. The other part is effective diffusibility. If you have a fairly high blood flow or the drug is very water soluble, put it that way. If the drug is very water soluble, it'll diffuse away from the nerve itself and therefore decreases the concentration of the nerve at the sodium channel, and therefore you have subtherapeutic amount of the drug at the sodium channel. The other one is on the vasodilator activity, is if there's a high blood flow in that area, also the drug will be carried away by the blood itself, and you also get less of the drug at the sodium channel, therefore will work quite as well. The other thing is fiber size and function. We know the large A alpha fibers, spoke about those back when I talking about pain, condition, electrical pain. The large A alpha fibers are motor nerves for the most part. The ones I'm mostly interested is the small delta fibers down here. These are the thinnest, and they're carrying pain, sharp pain. They carry sharp pain tissue, and they also signal tissue damage. These are very lightly myelinated. They're very thin, and they carry very sharp pain. The other one that's most important also too is the C fiber. I spoke about that one. The C fiber is a non-myelinated, very small fiber. These are the smallest and the thinnest of all of the nerve fibers, and they have much slower transmission and carrying what? Dull aching pain. Okay, so we know which ones are carrying on which. So this is the ones that are carrying the dull aching pain. And both of these, the C fibers, as well as the delta fibers, carry pain. And these two are primarily blocked by the same amount of local anesthetic. It's going to be there. So if we look at really what's happening here, these are the large A alpha fibers. And you have the nosoranvir, and you have saltatory conduction that's going to be there. So to get at a nerve, at a large A alpha fiber, you have to have at least 4 nosoranvir blocked so that you don't get a large jump across to the next fiber that would be there, the next node. The smaller A delta fibers here are very narrow, very small in terms of the diameter, and therefore they are very lightly myelinated, and they have their nosoranvir are much closer, and therefore they can be blocked quickly. And the small sensory postganglionic fibers, which are carrying the dull aching pain, there are no nosoranvir. There's very little myelin that is there, or no myelin that is there, and therefore, what does that say? They are sodium fibers, or sodium channels throughout the entire nerve fiber in and of itself. Okay. So the susceptibility of the blocked by the local anesthetics of types of nerve fibers. In general, the small nerve fibers are more susceptible than that of the large fibers. So, however, the type of fiber, the degree of myelination, the fiber length, and the frequency dependent. Remember that term because it's going to come up again and be able to explain some of the toxic adverse events that take place due to frequency dependence. All of these together are going to determine the susceptibility to do the blockade that's going to be there. If you have a very short fiber and they're non-myelinated, then the blockade is going to be very quick. That will be there for those. So the order of sensory blocked. Okay, when you inject the drug, what happens? We have the blockade of pain, then temperature, touch, deep pressure, and the last one to be blocked is motor. Now, how do we know that? Or how do you know that primarily? When you inject a patient, what do you do during that time, right after you inject the patient? You're usually still talking to that patient. And while you're talking to that patient, you're getting a lot of information on what's going on, because I'm waiting for the motor fiber to take effect. Because when the motor fiber is blocked by the local anesthetic, I can't understand what you're saying any longer because your speech becomes unintelligible. Therefore, I know I already have blocked pain, so I don't have to worry about whether or not you're going to be in pain. I know it because the motor fibers are blocked, because they're the last ones. Okay, because of the large amount of battery died again. Because of the large amount of myelin on the fibrin and it's up in and of itself. So the recovery obviously is going to be in the opposite direction that's going to take place. Recovery is in the reverse direction. Motor comes back first. So while you're in the chair, we're finishing up, and I begin to hear you talk again, and I can understand your words. I know that we're going back in the opposite direction. What do you do at that point? I want you out of that chair as fast as I can. Okay, why? Because pain's gonna come back before you're out of the room. And if I have other patients that are sitting in the waiting room, I don't want them hearing your pain that's going to take place. So the idea is there's very little chit chat that's going on after we're done. Thank you very much. We're done. See you next time. Okay, if you have any problems, give me a call. Goodbye. Okay, that's the way it usually works for most people, so that they can get in and out. Because by the time they get to the car, if I can understand what you're saying, by the time you get to your car and you have to block down the road, pain is starting to come back again for that individual. So been there, done it. Okay. Vasoconstrictors, why are they important? Vasoconstrictors become very important because they decrease the rate of vascular absorption. So if you have a fairly high blood flow in a certain area, you inject the drug, and I put a vasoconstrictor, usually epinephrine, at a concentration of 1 to 200,000. With that vasoconstrictor that is there, the blood flow is going to be much less. And therefore, the drug will stay put where I want it. Remember, I said, local anesthetics, you don't want it all over the body. You want it in one spot, and you want it to stay where you put it, that is there. You gotta be careful that the concentration of epinephrine stays fairly low. Otherwise, you'll stop all blood flow in that area, and you can have gangrene set up in a certain area over some period of time. So the advantage of the vasoconstrictor obviously will be decrease the blood flow, lower of the anesthetic blood levels, because you really don't want low in the blood in and of itself. Decreases the risk of toxicity that may be there, and also increase the duration of action, because the local anesthetic stays put where you actually put it, and decreases the bleeding that is going over there. So some of the complications that can take place, and they can be varied, and you don't have all of these at one time, but they may be in various amounts to be there. Obviously, you can have a broken needle. You really, don't want that. Obviously, that's more of a physical nature than anything else of the drug. If it's also prolonged anesthesia because the vasoconstriction is too long a period of time, the drug cannot be broken down, can't get back into blood supply in a short period of time and be broken down. You can have other things, facial paralysis, nerve paralysis, burning sensations on down the line. And then on the systemic side, if you have given too much drug, say for instance, you had an abscess, you gave too much drug, you injected 3-4 times in the exact same area, obviously that drug is going somewhere. It'll wind up in the systemic circulation, and you can have an overdose. And the last part is allergic reactions to the local anesthetic. Like I say, if I don't use a ester type linkage, I don't have to worry about it. So the non-linkage drugs are better. So the toxicities that can take place. Any questions? Okay, the toxicities that can take place are really of two types for the most part. Overdosage leads to a high blood level. So I'll explain how that can actually happen, where you just give it too much drug, or you gave the drug directly into a vein. So when you inject into the tissue, what do you do? The first thing that you do after you stick a needle in, you pull back. Okay, you pull back, and you pull back why? Because I want to determine whether or not I have any blood in that needle or not, because that determines if I'm in a vein. Okay, you do not want to inject the local anesthetic into a vein, because it can cause some very serious toxic effects that may be there. So use the smallest amount, most of the dilute amount that effectively blocks the pain that should be there. Hypersensitivity, I've already talked about the allergic responses that could be there with the ester type linkage and the parabenzoic acid metabolism that can take place. We're not going to go through that. So these are the clinical manifestations of an allergy that be there. Obviously, you can have fever, rash, photosensitivity, and then finally, if it's too high, anaphylaxis can occur in an individual, and if it's not taken care of very quickly, in terms of anaphylaxis, death can ensue very fast in itself. The treatment for that, for the particular the anaphylaxis, is steroids and H1 blockers that would be there to block the release of histamine and the steroids, and also a lot of times they give epinephrine. Those three drugs, epinephrine, H1 blockers, and steroids usually is able to reverse the anaphylaxis that may be there in the individual. This is going to be rare. It usually happens. It doesn't really happen that often, but it can in those individuals that are allergic. Now, the central nervous system toxicity is very important. Initially, it can cause a CNS excitation that can be there, followed by a CNS depression. Why? What happens? What goes on in this case? All right. There are inhibitory impulses as well as excitatory impulses on the brain at all times. Okay. And right now it's getting past lunch, and everyone's getting tired. And so I see eyes beginning to close down, and therefore we're now beginning to see inhibitory impulses overriding the stimulated activity that's taking place. So anyway, if we can block remember that I said what the drugs do. They block those nerve fibers that are firing at the fastest rate first. Keep that in mind, very important. Because when nerve fibers in the brain are firing at the fastest rate, the inhibitory fibers. Yeah. Okay, GABA is an inhibitory neuron, and those primarily are interneurons. Those interneurons are firing at a much faster rate than the stimulatory fibers that are firing. And therefore, because they're firing at a fast rate, it keeps us all nice and calm in the sitting position, and we're not making a lot of noise and not going around. Okay, so we know that the GABA fibers fire. However, because they're firing so fast, if a local anesthetic in high concentration gets into the brain, they inhibit the inhibitory GABA neurons. So you have inhibition of inhibition that's taking place. All right, which means what's left? The only thing I have left is excitation. That excitation is convulsions that you will see in an individual. As the concentration increases even higher, then they would then block the stimulatory fibers as well too, and therefore I now have the CNS depression that can take place in an individual. And that CNS depression can be with excitation, the convulsions that can take place. The triggers start, person starts to shake like shivering, that can take place, and then you have a frank convulsion that would be there. The depression characterized by a CNS depression, sedation, and finally respiratory depression that can take place, and then death can ensue if the dose is that high. All right. So you have two things that can take place: the antiarrhythmic part and the anticonvulsive part at a normal therapeutic concentration. Higher than that, you can have the muscle twitching that can take place. The person looks like they're shivering to some extent. They become unconscious for the most part, then coma, respiratory arrest, then finally cardiovascular depression and respiratory arrest would take place for that individual. The person could die. So what's the other side of it? Cardiovascular toxicity. If they're absorbed into the systemic circulation, again at higher concentrations, remember the local anesthetics don't care where they see a nerve, a sodium channel. They block all sodium channels, irrespective of where you inject it, if it gets into the systemic blood flow. And therefore, because of that, they can get into the blood flow and get to the heart in and of itself. What do they block first? What's the first thing that fires in the heart? What nerve? SA node, followed by AV node, followed by Purkinje fibers, followed by both of this, the Purkinje fibers, okay? So we gotta go back to cardiovascular all over. So if the SA node stops firing, what happens in the heart? Then the AV node picks it up to keep the heart in the automatic firing sequence that we did there, and you don't have arrhythmias that take place. But the local anesthetic, because it's gotten into the bloodstream and it goes right to the heart, is going to affect SA node, AV node, his functions, and then the Purkinje fibers. The heart doesn't work. What happens to the heart? Cardiac standstill. Heart stops. There's no firing that will take place. This explains why sometimes when you hear it on the news every single year, we hear it on the news. You have some kid out there on the basketball court, and it's in the middle of July, it's hot. They haven't had enough water, and they just snorted a couple lines of coke. They go out there playing basketball, they hit up a layup, hit the ground, and they're dead. Why? Why are they dead? Because the drug has gotten into the heart. Cocaine is a local anesthetic, okay? It affects the sodium channels. Therefore, it blocks AV node, the SA node, AV node, his bundles, and then the Purkinje fibers. The heart goes into a cardiac standstill. Everything stops. Now, here comes EMT, real quick, they're around the corner. Here they come, and they use cardioversion. Will it work? If I use cardioversion on that patient, will it work? Yes, no, it won't work. Why? Because you still have local anesthetic sitting at the sodium channels. So no matter if you do get more fluid and you're trying to get the heart restarted and you do cardioversion, you cannot turn the switch back on again because you have overloaded the system. Basically, with the local anesthetic at the SA node, AV node, runs the his and Purkinje fibers, and they're still sitting there and moving. As long as they're there, there's no generation of an action potential in the heart, and the heart just stops for the most part, okay? All right, any questions on that? On CD, of the CNS or the cardiovascular system? Okay. So the signs of toxicity really occur on the continuum that will be there. Early to late stages of toxicity, you begin to get oral and tongue numbness at first. Okay, followed by lightheadedness, ringing in the ears, visual disturbances, things go from color to black and white. Okay, and you get more tunnel vision that would be there, twitching of the muscles that would be there, particularly in the extremities first, and then you get frank convulsions, followed then by an unconscious individual coma, and then finally respiratory and cardiovascular collapse. That would be the end of it. Now, we're talking about a fairly high dose here. We're not talking about a normal one syringe that you inject a product. We're talking about several amounts of drug that has been given, and you inject it directly into a vein instead of the tissue in and of itself. This is what can happen to an individual. So you can see these drugs are not innocuous, and they can cause fatality, and it does occur in individuals, so you gotta be careful. So the treatment, if you're quick for the CNS toxicities, you can treat minor reactions fairly easy. Just give O2, give us some time, and they probably will terminate in and of itself. The seizures, you give midazolam would be the best drug in that case, midazolam propofol, something like that. It will be useful intubate a patient that has a full stomach so they don't vomit that back up, and then you have respiratory pneumonia that can take place because you get into the lung. If there's a cardiovascular toxicity, you can substitute, particularly for lidocaine. This only works really for lidocaine. That's the other type of local anesthetics. Amiodarone would work, but you also have to think about cardiopulmonary bypass or lipid infusion of other drugs if everything fails. Usually, this would only happen really in a hospital setting. That would be there. This is not the example that I gave you is not one that you can turn around and then get the heart restarted very easily. This is a very serious matter when the heart stops and goes into a cardiac standstill. That can take place with an individual. Adverse effects, continuing on with that, pralocaine and lidocaine are classified as the myotype linkage drugs. And therefore, they're hydrolyzed into metabolites of O-toluidine and 2,6-xylidine, and these are suspected to cause methylmyoglobia in individuals, and you usually can treat methylmyoglobia fairly easily with methylene blue or even anything that has ascorbic acid like vitamin C infused into an individual, and it'll convert the reduced ferrous or the iron that carries the oxygen into an oxygen carrying state that would be there for you to have. Again, this is one that is rare that can be there. It usually only happens when you're using both of these drugs together, pralocaine and lidocaine. I wouldn't suggest using both, but there are times when both of them are used together. Okay. So, what choice of anesthetic do you use? A lot of it depends on experience. Really, a lot of it will depend on your experience that you have gained over a certain amount of years that be there. So, other patient factors, the age of the patient. Patient that is fairly elderly, you don't want to use as much local anesthetic because you think about if this gets into the systemic circulation, the events that can happen, particularly on the cardiovascular system. The pregnancy status, history of allergies. If I know you're allergic to a ester type drug, just go to the doctor right from the start. Other medical conditions, if I have hepatic failure, then I got to think about how much of the type drug can I give, because what's going to happen? It's not going to be broken down as fast as you want it. And therefore, the duration of action actually may be lifted out longer than you really want. So a lot of that is basically history that would be there. And the other thing is current medication that a person is taking. All of this is done during the history taken. Because why is this important? In terms of current medication, the drugs don't have a drug-drug interaction, but they primarily have a drug metabolism interaction that can be there, particularly if you have drugs that are going to be metabolized by the same P450 system, either the CYP4, CYP3 are the main metabolic agents that will be there, and therefore You don't wanna have other drugs that are being metabolized and your drug being a mild type of things, because I thought about it and said, oh, I'm not gonna use an ester type, but I'll use a mild type if the person has some back problems that are there. Other thing is again, consider the site that you're using, the area, and how much time for the type of operation that you need to use. Is it something that can be done in 15 to 20 minutes? Or is it something that's gonna take 2 hours? Again, all of that really breaks down to experience. You know, some people are very fast, and some people are very slow. So if I'm very slow, I need a fairly longer acting drug because I don't want to re-inject. Last thing you want to do is re-inject again and again because the drug will go off in the middle of its taking place. So the types in the last few minutes that we have, the type of blocks that we have at the top of the block may be accomplished by putting it on the mucous membranes. These are things that you can easily use on the eye, for instance, on the skin. A lot of can put on the skin. They use a lot of the top of the block a lot of times for any type of examination that may be there. And a lot of times really is for children that are teething. Children that are teething, they're used sort of a top of the block there, so it eases the pain instead of child is crying. Surface anesthesia relieves burning and itching, surface pain, sunburn, things of that nature. So you have local anesthetics involved in those. And in fact, at the level of the skin, they really don't go any further and they don't get into the systemic circulation. Nerve blocks, for the most part, these are ones that lead to operative sites that you're going to be doing. And so if you're going to do a nerve block, again, it goes back to experience of which drug to use and what's going to be the length of that operation is going to be there. So in terms of blocking, usually drugs, like I said, depending on where you're blocking, local infiltration, a field block or nerve block, that may have to be there. If it's a local infiltration, then you're very close to the nerve endings that will be there. Therefore, that's where you would block. It may be a little bit higher up on a field block, that may be there. With the nerve block further away, why would you use that if there's inflammation? I need to do some surgery in this area that I have here, and I need to do some surgery that's there. I'm not going to inject there because what's happening? I have an abscess. And because an abscess, the pH is too low, I know it's acidic, but I'll move up to the nerve block itself, and I'll block the entire nerve that will be there for some period of time. And deep bridge the abscess that will be there. Peridural anesthesia is really where you're giving it in the peridural space, primarily in the spinal cord. These are very serious operations. You're using, I know y'all won't be doing those type, 4 or 5 hour type of surgery that you're doing. And the last one, the spinal anesthetics that you're using, where these are injected directly into the subarachnoid space of the spinal cord. And therefore, these are very serious operations. I need the patient to wait because I can talk to them, but they don't feel any pain that's going on at the same time. And therefore, that's why you give a much longer acting drugs, 4 or 5 hours, bupivacaine or bupivacaine. Okay, universal safety guidelines, aspirate the area before injecting to make sure you're in the right area that you really want to be. Okay, that you really want to be there. Inject slowly. Don't inject at one bolus. And what I say, when you put the needle in, you do what? Pull back. First thing you do is pull back, make sure that you're not in the vein. Monitor the patient closely during the time that you have injected the drug into the patient. That's why you have to stay there and you have to talk to the patient to make sure they're okay, that they find, the pain is going away, and then the motor stops. You don't want them falling asleep. Okay, that's the last thing you want to do before the local, because then you've given the drug in the wrong spot. But which vasoconstrictor that you're going to be using, or the concentration that you're going to be using as well too. Use a minimum amount of anesthetic solution for the most part, and adhere to the simple guidelines that I primarily just went through. There's other things you have to do as well too, and we don't really have the time to go all the details that may be there. So there's one little other. Any questions? Take it all time. You didn't believe I could do it. Okay. Any questions at all? You have a question? They're small. They're trying to very actually. If, so you don't experience. Looks like the size of the generator, that also which there's which you created. That's the real. Those are the. I talked about those, the nerve works critical. They're inactive channels. So if the nerve is very actuated. Propensity of